All right, guys, we're doing part 2 of our chapter 36. Our first part was talking about the anatomical and physiologic differences of the pediatric patient versus an adult patient. And today we're going to talk about some of the disease processes and the pathophysiology of the disease process, but we're not going to go too in depth on that because you've already seen these. What we are going to discuss is how does affect pediatric patients different than adult patients. So this is a 140 slide presentation. We are probably not going to go into detail over every last little thing. You will obviously have the slide. You will have this presentation, the slideshow in this presentation. You'll be able to go over at your leisure. I probably am going to go kind of quickly because I just want to point out, again, just the differences between the pediatric patient and the adult patient and your treatment modalities. Like we've already said, we're looking at the fact that kids have to have a faster heart rate, faster respiratory rate. They do pound per pound technically have a higher percentage of blood circulation or blood volume circulating, but overall they definitely have way less blood volume. So with that being said, they've got to compensate to try to perfuse, so they pump blood faster to take the oxygen, transport it, gas exchange, cellular respiration, oxygenation, all that good jazz. So that's what we're looking for. But one of the things that you do need to consider is if you're going to transport these patients and you have a pediatric patient, you probably need to go to a pediatric facility, especially if they're pretty stable. And I will do this, stable. You're going to have to kind of make the decision whether or not you feel that they're stable enough to go on a transport, because usually that's going to mean a drive. I think you guys in Rome probably have a pediatric hospital, maybe hopefully close by. I don't know. I know you have several there. I wish I was more educated in your region or your area, but I know for us, we do not. All of Northeast Georgia does not have a pediatric hospital, not even in Gainesville. So everything has to go to Atlanta. And there are 2 in Atlanta. And we do have one, and you guys probably utilize this one more than anything, T.C. Thompson in Erlanger. So over in Chattanooga. So those are where you would probably be looking to go. If you have to airlift them, if they're that sick, you can do that. That's always an option. So remember, consider your pediatric emergency departments, because, like I said, children are not small people or small adults. They have their own unique set of rules that they play by. Signs of respiratory distress, really the one I want you to pay attention to, or the ones I want you to pay attention to the most, is grunting, nasal flaring, abdominal breathing, and retractions. That's pretty much, that's pretty common for kids. You may not see in adults so much as you do in kids. If you do see them in adults, they're really bad, real sick. Failure is meaning that they no longer can compensate, and they're going to probably start having altered mental status, anxiety, confusion. That's when you really need to start being aggressive, because remember, kids are great, and then no, they're not. They'll be good, then nope. So remember, kids will sustain longer than adults will. Respiratory arrest means the patient is not breathing spontaneously. We're just going to leave that at that. You will have to BVM, high flow oxygen. Well, let's just move on. If you are having respiratory distress, don't consider the following. Do the following. You can give supplemental O2. Probably want to do a non-rebreather, especially if you got a sick kid. One of the things we will talk about later is that maybe if a kid can't tolerate it, if they don't want the mask on their face, you can always try to do blow-by, but blow-by is not as effective as actually putting them on like a nasal cannula or a non-rebreather. We'll talk about that here in a little bit. You can use the EKG monitor. You can use the cardiac monitor, even though you're not. You can put the leads on them and actually get an accurate heart rate, because if you're trying to use the pulse oximeter, you probably have an accurate heart rate. But if you're really just not sure, it's kind of jumping around, or their fingers are cold and you don't think it's reading accurately, put them on the cardiac monitor. That's fine. IV access, especially if you have concerns with dehydration, which we will talk about here in a little bit. You're not wrong for doing that. Just got to be good at it. That's all I got to say. You got to be good at it. Kids are hard sticks. They're not difficult sticks. They're just a little tougher, and you will have to use smaller equipment. The airway should be managed in the least invasive way. It all depends. We're gonna talk about that as we go. Foreign body obstruction. Remember, kids put everything in their mouth, especially the younger they are. So they can put things. They can put things in their mouth. And they can choke on it. They can bite off more than they can chew. and candy. Candy's a huge culprit, and gum. It's a huge culprit of being a foreign body airway obstruction. Same rules still apply. If they can cough, they can breathe. They've got a little bit of stridor, but they're still moving air. Go ahead and let them cough. Do not blind finger sweep. If they do lose consciousness, or if it becomes a complete airway body obstruction and they're still conscious, again, the Heimlich is the preferred maneuver. When they go unconscious, go ahead and start your CPR. If they're less than a year, don't forget the choking infant. 5 back blows, then 5 chest compressions, then rotate back and forth if they're under a year. Anaphylaxis. We talk about anaphylaxis. It's an exaggerated, extremely exaggerated immune response to a pathogen or a foreign invader, what at least the body feels is foreign invader. It could be shrimp, it could be medication, it could be anything. So it's still the same idea. The gold standard is epi, which you guys are learning, your 1 to 1,000 concentration of epinephrine. You can also use Benadryl, which is not within your scope of practice, but I will throw out this caveat to you. If mom and dad have like children's Benadryl and liquid Benadryl and the kid is still able to swallow, I'm not saying give it to them. I'm just saying that in the event that you feel you need to use the resources at your disposal, if the parents want to give it to them, that's at their discretion, if you're picking up what I'm throwing down. All right, croup. We're going to talk about croup and epiglottitis. And bronchiolitis. These are respiratory conditions that are pretty much specific to children. Croup is where they have, they call it the parainfluenza virus. It's just underneath the glottic opening, so right under the vocal cords. So the glottic opening is the vocal cords. Where this infection sets up is right underneath there. Now remember, when we talked about the anatomical differences of children, where's the most narrowest part of their airway? It's not like adults. It's not the glottic opening itself. It's just below it. So here you have a pediatric patient that has specific infection for croup, and it's right underneath the glottic opening, which is the narrowest part of the airway already, and now you're going to take it and make it more narrow. So usually it's characterized by stridor. They'll have like a stridor breathing. Seal bark cough is what they also say. Kind of like I really can't do it for you, but it's a seal bark cough. Usually their airway, or not their airway, but their lungs will be clear to auscultation bilaterally. They won't really have any junk, wheezing, rails, crackles, none of that. It's just, they'll just have stridor. And so what you usually want to do is, it's called racemic epi, and it usually is kind of hard to find in the EMS world. Some services carry it, some don't, but you can nebulize epi to help dilate that open, or in and around that swollen airway. Don't want to mess with these kids too bad. You can humidify the oxygen, meaning that you can take oxygen and put it in a neb treatment and just put normal saline in it. And you can nebulize the normal saline. That's kind of like how you can humidify it if you don't have a humidifier for the oxygen itself. Here's an illustration. Epiglottitis. Now, this is kind of on the other side. This is where the epiglottis above the glottic opening gets inflamed. Just remember, the epiglottis is when you swallow. It's what covers the trachea to allow food and materials and particles to go down in the esophagus for digestion. This is where this becomes extremely inflamed, and the child will be more than likely tripod positioned. They will be more than likely be focused on just breathing. They will not be swallowing because it's very painful to swallow, and they'll probably be drooling. This is the child that you do not want to mess with. You do not want to mess with this child. You don't want to start an IV. You don't want to piss them off. You don't want them screaming and crying, because that's going to aggravate the airway further to the point where it swells off. It's already going to be bad enough as it is. They teach paramedic students that, like, if you have to intubate this child, you need to be good at it, and you need to get it done in one and done. Like, you've got to be good at getting this airway. Otherwise, all you're going to do is just cause some more aggravation and inflammation and swelling to this airway by going in and with the laryngoscope and trying to get it. and you're going to lose the airway. So that's the big concern, is the fact that this airway is becoming more swollen and endeminous, and it might swell off and you'll lose it. So they're always afraid that they're going to have to crike these kids. Best to not mess with them if you can help it. And that includes, don't look in their mouth, don't attempt IVs. If you have to BBM them, fine. Just do what you got to do to maintain them the best possible you can without aggravating them. Lower airways, that's going to be your wheezing, your crackling, your rails. They talk about asthma. Asthma is big in children. It has to do with kind of like a reactive airway. Basically, there's something that's in the air that causes their airway to react. It kind of falls underneath the immunological allergic or reaction type deal, and it is kind of the same. But the only problem is with this is that you also got now the mucus production. You'll have the swelling and the inflammation, but the mucus production, which that mucus will fill up the airway and it'll block off, and then you'll have like in here that you'll have air trapping, like it'll be trapped in the alveoli, so they can't get a good exhalation out. So it's good to try to reverse that if possible. That's also done with usually it's going to be albuterol or Duonab, stuff like that. Wheezing is really big in this. You will have wheezing because it's that musical sound because the airway is constricting down, and the mucus production is also going to have it constricted, not constricted down, but also blocking the airway as well. Tachycardia, tachypnea, it'd be in the tripod position, kind of the same stuff for all the difficulty breathing stuff. O2 by non-rebreather, if you can, probably want to neb in some Duonebs. I have to, or their MDI. They may have their own meter dose inhaler, which you can absolutely help them with to try to correct the airway constriction. Map to tube them, but that's a paramedic skill. Monitor their O2 stats. Just keep an eye on them. Continue to do a respiratory assessment as well. You want to know if the wheezing is getting worse or getting better, because it may be that you're nebbing in, but you may have to do more Duonebs or more breathing treatments or more albuterol. So keep that in mind too. Pneumonia, that's basically where the alveolar or sac gets infection and pus from an infection. Kids have it, adults have it. It's kind of the same pathophysiology. There will be crackles. That's where, because there is fluid in the lower airway. So you'll have swelling or inflammation in the bronchioles, the alveoli as well, and the fluid and pus buildup. And usually when they do a chest x-ray, it's going to be white down in the lower lobes because it's fluid. So that's usually typically the pus, and they'll be coughing up nasty yellow junky stuff. So there's always that. Bronchiolitis. This is kind of like for kids. This is like bronchitis for kids. They're not going to get bronchitis. Now, they can get bronchitis. It's not saying they can't, but they might get bronchiolitis. And it's usually off the RSV, and it's the same thing. You've got for us, the bronchi get constricted, inflamed, irritated. Same thing. Their bronchioles will get inflamed, infected. They'll probably have a fever that goes well with it, along with this as well. And they'll fill with mucus, and it's bad juju. So it's just like bronchitis, but for kids, and it's bronchiolitis. Pertussis, also known as whooping cough. If kids don't get their vaccinations, they are probably privy to this. It would be nice to know that pertussis has been eradicated, but it has not. So usually whooping cough is part of the DTaP immunization. So usually it's known as a progressive cough. As far as when they cough, it's just kind of a whoop. I don't know how else to do it, but it does sound like a whoop. I have heard it before. It sounds actually uncanny like a whoop. So I picked up a kid with it before. So now we're gonna get into something. This is hard to see. So when you pull up your PowerPoint on your own, this is called a Breslau tape. And they actually make Breslau kits. And Breslau kits are basically what you can do. It's kind of like the cheat sheet of kits, because obviously everything's weight-based dosed and everything's different sizes. So What it is, they took kind of like the average. And what you do is you place one end at the child's head, and then you lay this out. And wherever their feet fall in this color-coded, because you got red, purple, yellow, white, blue, orange. And wherever they fall, you have a group or a pre-packed determined color set up. And you grab that out, and all of that you can use. And in here on this, it'll give you dosing for all kinds of medications. Narcan, morphine, whatever. Just whatever you might need. Epinephrine, 1 to 10,000, 1 to 1,000. It'll give you everything you need to know, including airway adjunct size, MPA sizes. Now remember, this is based on the average child. There are some kids that are not going to be average. Just keep that in mind. So you may have to bump up or bump down from there, but it gives you a good starting place on where to go. OPAs, it's kind of the same thing. You just got to watch out. Remember, the tongue is proportionally larger compared to an adult inside the mouth, so you're more than likely going to have that as a blockage if you're going to have an airway obstruction, especially if the child is unresponsive. So you want to make sure there's no gag reflex. If they are going to vomit, that's bad. Tongue blade, use it if you can. If not, do the technique upside down and twist as you go in. Try not to avoid injuring the hard palate. NPAs, usually you're not going to use them in kids less than a year old because they don't make them that fit. Remember, you still got to measure them. You got to still put them in. Remember, kids are obligate nose breathers too, so especially when they're younger, so be careful with that. Oxygen delivery devices. All right, so there's something called blow-by, and blow-by is where you take it and you try to blow, like a kid won't tolerate, or even an adult won't tolerate a mask. Maybe they're claustrophobic or they don't want it on them. Usually kids are just like, no, get it off me now. And what you'll do is you'll just take it, place it underneath their chin, and let it just blow up by them. That's blow-by. It's a lot of debate. It works, maybe. I'm not a big fan of blow-by, but I also believe it's better than nothing. There are some people that are like, well, blow-by just doesn't work and it's retarded. Because look at what they're saying, 21% oxygen concentration. Well, at 6 liters per minute, 21% oxygen concentration, you may as well just breathe room air. It's the same thing. So then they talk about percentages from going forward for that. So if you do get them on a nasal cannula, between 1 and 6 liters, it's 24 to 44%. Non-rebreathers, 90-95%. And BVM is pretty much 90 to almost 100%. So that's what they want to talk about. Blow-by, they're talking about this and more about it. You guys already know about this stuff, and we just kind of discussed it right then and there. One of the things that they do want to point out, if you are going to have to BVM a kid, you're going to have to use the BVM on a child. What they're saying is that they want or feel that it's a good idea to have 2 people. Good luck with that. I don't disagree with that statement. I would love to have 2 people, one person holding and doing a CE grip or a dual CE grip, holding the mask itself, and then one person doing ventilations and watching for chest rise and giving adequate ventilations and doing a good count. But that's not always going to be feasibly possible. Remember, it's just you and your partner, and you guys pretty much have to divide and conquer to try to meet in the middle somewhere. So having 2 people just to ventilate a kid, unless it's just you and your partner, nothing else is going on, and you don't have to do anything else, that's fine, that's fantastic. But good luck with that. I really don't know if you can adequately do that, but it is recommended and it is preferred, so I had to tell you that. CPR, we've covered CPR. You guys have already been CPR certified. We're not going to beat this to death. Shock, we haven't really gone through shock trauma. But just keep in mind, we're going to point out some of the differences for kids. That way you can keep it in your mind when we're doing it for shock trauma the next segment when we move on. Signs like tachycardia, poor cap refill time, mental status changes, stuff like that. Blood pressure may be difficult to measure. Usually kind of one of the telltale signs for shock in adults is their heart rate goes up, their blood pressure goes up, and they're compensating. And it's called compensated shock. Well, kids, getting a blood pressure is not easy because you've got to have the correct size cuff. They make different size cuffs, and kids are all come in different sizes and shapes. So it's not easy to always have 5 or 6 cuffs ready and available. Some services actually carry manual cuffs that are like that, you can literally kind of plug and play the size that you need and maybe get an accurate blood pressure, but that does take time, especially when it's manual, and especially when you're looking to be moving. If something's really going south, you don't really need it. I usually judge kids' perfusion status on their skin color, their skin tone, their mental status, and how well their SpO2 reading is. I'll kind of judge off heart rate and SpO2 as well. So that's how I'll do it. It's not ideal. I'm not saying it's ideal, but usually it's kind of how I just judge a kid. And again, mom or dad, or a caregiver, like, is this normal? Is the child acting normal? Are they acting upset, confused, inconsolable, meaning that they might be actually having some air hunger or some oxygen starvation? So that's how I do it. You don't have to do it. You can do it whatever way works for you, but that's how I suggest it. One of the things that you do want to look for, and we will talk about this in later, and I guess if I kind of talk about it now, we kind of blow through it when we get there, is dehydration. One of the things that you want to look for is their hydration level, and nothing will kill that faster than diarrhea or vomiting. And I'll say nausea, vomiting, because obviously they'll be nauseated to throw up, but that will kill their hydration status faster than anything, and it will wipe it out in a matter of hours. So, asking about wet diapers, looking at their fontanelles to see if they're sunk in, looking at, obviously that's for infants, but kind of looking around their eyes to see if they're sunk in. I know it can change very, very quickly, and I've seen kids, and it doesn't have to be infants. I've seen 10-year-old kids and 12-year-old kids that have kind of sunk in eyes. They're just not eating and drinking very well because they've been sick, just not feeling good. So you want to make sure you judge their perfusion status. Anaphylactic shock, why we're still talking about that, I don't know why it's still here, but it's there. We've already talked about that. Bleeding disorders, we've already talked about that. Still stands the same. Again, the only thing different is kids have less volume than adults. Pound per pound, percentage-wise, they have more. But remember, they don't weigh that much. So they have less. So if we lose 500 milliliters of blood, okay. But if they lose 250, that's a big deal. So just keep that in mind. Altered mental status, they start talking about neurological emergencies. They use AEIO tips. It's really you can use AEIOU tips for all altered mental status. I put a picture in here for you so you can kind of refer back to it in case you need to look at it, or if there's a quiz question, you might be able to reference it. Not sure if there will be or not. Seizures. Let's get to the point where it really says for management. We'll cover management first. So obviously, if anyone's seizing, you want to pretty much clear out everything or space around them so they'll seize and they won't hit, especially with having a grand mal seizure. They won't hit or bang up against anything. They won't injure themselves any further than they already have. Because obviously when they have a seizure, typically they're going to go from a standing position, they're going to fall. Unless they do have an aura and they recognize that they need to lay down, and they'll lay down and have their seizures. That's true as well. Suction, go ahead and suction. Provide 100% oxygen, be a non-rebreather if you can. But this is the big dog for kids. This is the one I'm going to kind of stress on, febrile seizures. And what that is that basically they have an increase in temperature or body core temperature that's very quick. And it's very quick. And it could be that they're fine and all of a sudden they are getting sick, coming down with something, their temperature spikes up. And what the body does is the body recognizes that that the body is under attack, and it says, okay, I'm going to set the fever limit or the heat ratio. I'm going to set it up. I'm going to set the point up to here now. We're not here anymore. We're not going to be 98.6. I want it to be 102. And so if it happens very quickly, they can have a febrile seizure. Where I most commonly see it at, or have seen it at, is that parents do want to treat you want to treat the fever. And what you can do is every 8 hours, you can give Motrin, and every 8 hours you can give Tylenol, and you can rotate them. And what you do is you start with one. Say you start with Motrin. 8 hours later, you'll be able to give Motrin again. But in between, 4 hour period, you can go ahead and give Tylenol. So you can go every 4 hours, Motrin, Tylenol, Motrin, Tylenol, Motrin, Tylenol, Motrin, Tylenol. You can keep that going, and that will help combat fever. Where I see the febrile seizure usually or typically happen is at the end of where one of them's wearing off at the end of the 4-hour period. You gave Motrin, that's cool. And then you gave Tylenol. Well, they've got both of those in their system. They're hanging out. They're good. And then when the Motrin starts wearing off and it's time for another dose of Motrin, maybe the Tylenol might be wearing off as well. Or they don't rotate them and they just do it every 8 hours. That's usually where you see it the worst. Like it'll start wearing off, wearing down, and the fever point that's set to here has been suppressed by the Motrin and the Tylenol, and all of a sudden it starts wearing off and it goes back up, and that's where you see the febrile seizure. It's such a quick, rapid increase of temperature. So again, you can see when they first initially get sick, and all of a sudden they're having a seizure. Mom and dad are flipping out, going, "Oh my God, what the hell?" They don't have a history of seizures, like they've never had a seizure in their life. And unfortunately, I don't want to say they're common, but they are kind of common for kids to have. So I'm not saying it should be normal. Don't consider it as if it's normal, and don't downplay it. But with that being said, it does happen quite a bit. Keep them kind of cool. Manage the ABCDEs. Be careful with how you cool them. They're saying use tepid water, which means kind of warm. Just kind of keep them warm. But remember, once you put water on them, like water will pull heat from the body very quickly. So they will get cooled down very quickly. So, but also check their glucose. Make sure they haven't burned up too much glucose, because even if they do have a seizure, that'll burn a lot of calories. Meningitis, we've already talked about. It's a communicable disease. Usually the telltale sign is going to be where you have, usually it's the college dorm, and one of the roommates calls 911 because their friend is ultra sensitive to light, complaining of extreme neck pain, and running a fever. That's usually the one that if you get that scenario, more than likely it sounds like it's meningitis. Really for the infants though, if they do catch meningitis, really for like the infant, the ones that can't communicate, they don't like being moved. And they might have bulging fontanelles. So, like, remember, the meninges are irritated and inflamed. And remember the neck pain. So, you know, when you're picking up baby, you grab it, you scoop it up, and you're holding it by the neck. Well, it just irritates the crap out of them. And you holding them and them having to move makes them really pissed off mad. And they're probably running a fever as well. So, that might be the things that kind of clue you into the baby may have meningitis. They just don't want to be moved, got a fever, they're really irritable, and bulging fontanelles. Also, allegedly, like, there's some sort of, I've never seen this, so there's like a purplish rash. If it's on the trunk, on the legs, that might be a telltale sign that it might be meningitis. I've never seen this, so this is new to me, so I'm just passing this information on to you. Treatment's still the same: IV, O2, transport, manage fever. GI stuff, it's still the same. The bleeding, GI bleed, it's an insidious bleed. It can hold a lot of blood. The abdominal cavity can hold a lot of blood before you really start noticing it. Kids also too, if they got tummy pain, they're not gonna be able to tell you. Appendicitis in kids is very common. I was blown away. I've actually heard of, since I've been in this business, kids having it as much as adults. I've never had my appendix out, had my gallbladder out, but not my appendix. But I do know that there's several children that were friends with my daughters that have had their appendix removed. So it's crazy, but it does happen. Kind of the same signs and symptoms. Usually umbilical pain, radiates down the right lower quadrant, stuff like that. Ask your good sample questions. Hydration status, wet diapers, keeping it down. I think we're kind of getting into that. We will here after this, I think. Poisoning. Remember, kids stick everything in their mouth. They're going to put everything, and it could be unintentional. Like, no one's going to judge mom or dad. That's one of the things that their mom and dad are really concerned with, is that, oh God, my son or daughter, I don't know what's wrong with them. I think they may ate a pill. It's my fault. And it's not. Things happen. You don't get a chance to pick up everything or vacuum everything. And maybe somebody's visiting, or like mom or their mom and dad, which would be grandma, grandpa, are visiting, and they're going to go take the pills, spilled them, whatever. and there they are. They ate a blood pressure pill, and then the child is fine 1 minute, and they eat this pill, and then they pass out because their blood pressure is tanking the next. So, or it might be simple. They may have gotten something that they know exactly what it is, and you're able to call poison control. There's a number to poison control. It is area code specific. I have a North Carolina phone, but I call from Georgia, but they still help me anyways. They just can't recommend what hospitals to go to because they have all that information. It's a good resource, good number to have in your phone. So you can call, and it doesn't matter about pediatrics, adults, it doesn't matter. It's the poison control hotline. You can basically call that and be like, help, I have this or I have that. What do I do? And they'll like, well, you can use this as an antidote, that as an antidote. You probably want, and they'll probably say you got to call and get medical direction for it. And then you can go online and say, hey, listen, I was on poison control. This is what they recommend, doc. This is what they're saying. And usually the doc will go, okay, the poison control recommended it. Fantastic. Go with it. Common things that they can eat that'll cause them altermentation. Confused and sleepy. Kind of the same things. One of the key things you want to ask is if they know what substance was involved, how much the substance was done, when it happened, has the kid vomited. Weight is important because you may wind up giving activated charcoal, and it is a weight-based dosing for children. Remember, all drugs are weight-based dosing for children. And is there any changes? Is this their normal, or is this a new new? So, if you can remove whatever is in their mouth, remove it. Try to stop that. Brush it off. Maintain ABCs. Be prepared for signs of shock, which we'll talk about. Activated charcoal, 0.5 to 1 gram per kilogram of body weight. We did talk about dehydration. Vomiting and diarrhea are the most common causes, and will dehydrate them in a matter of hours. Manage their ABCs. You want to fever. We already kind of talked about febrile seizure. What's typically considered fever, 100.4 degrees or higher. Those are the common aspects. Basically, they've got some sort of infection somewhere going on. That's typically why they have fever. Those are the fever or the normal body temperature ranges. Viral bacterial infection. Kind of skipping through this, guys, because you already know this. I know you know this. Glucose level. So if you have any altered mentation or any altered mental status, one of the things you want to check is your glucose level. See if it's low. See if it's high. Because either way, you're probably gonna have to do something about it. Always give 100% oxygen. One of the things, so if they are hypoglycemic, for ages 1 year and older, you want to do D25. You actually have to make that. You have to take D50 and cut it in half. That's pretty easy. You can take the D50, amp a D50, squeeze out half of it, and then draw in the whatever you just squeezed out of normal saline, and that'll cut it down to D25. D10, I can show you how to make that. That's pretty simple. But again, usually a year, they're not saying it, but usually a year or younger, you'll use D10 and not a lot of it because remember, it's weight-based. D25 for a year or older, and then once you get up to about adulthood, probably about 100 pounds. That's probably when you start using like D50, roughly in around there. Don't quote me on that. Hyperglycemic, one of the things that if they are like a type 1, you want to know if they're on their insulin. It should be here somewhere. If they're on their insulin, what do they take? Probably start some fluids, hang fluids, but don't give them too rapidly. Just kind of start a nice TKO infusion because fluids are going to help move that sugar out through the renal system. Drowning. So, knock on wood, I have not had to run a kid drowning. And I work in and around a bunch of lakes. Everywhere I work, there's a lake somewhere. And a lot of coastline of the lake. So, with that being said, it doesn't have to be just a kid in a lake. It could be in a swimming pool. It could be in a bathtub. It doesn't take much to drown, for a child to drown. Just a couple inches of water and being left unattended. And I'm not saying that it was intentionally left unattended. You know, mom could be filling up bath water and the kid just happens to get in. So, it happens. If adolescence is typically going to be alcohol related, so be prepared for that. Drowning, you handle like a cardiac arrest, but you've got to somehow get the fluid out of the lungs if possible. If you're able to intubate, or your paramedic partner is able to intubate, you can probably suction using a French soft suction. Probably try to suction out as much of that stuff as you can. And I'm telling you, lake water is nasty. If you can just basically kind of roll them on the side and let it run out, that's a possibility too. If it's cold water drownings, there's a higher rate of survival because metabolically they shut down because of the cold. So there's a good higher survivability of that, which is sad because usually it's during summer when we usually have a drowning. And they usually happen once or twice a year on every lake. So, and usually it's during the summer. So it's sad. I've worked a drowning victim before, but it has not been a child, thank goodness. It was actually an adult. And they had to jump in and find them, and we tried to work them, but no, we weren't able to resuscitate them. Same thing, just cervical collar. So one of the things you need to consider is that the fact that when they jumped in, it may not be they drowned because they couldn't swim or they got fatigued or tired and went under. It could be that they lost consciousness, they hit their head, broke their neck, and things of that nature. So, especially with kids, cervical collar, probably pad the shoulders, do your chest compressions, stuff like that. Usually, depends on the size of the child, one hand, stuff like that. Trauma, I'm gonna kind of blow through this trauma because we're gonna talk about trauma, and trauma is pretty much the same for pediatrics as it is for adults, but I am going to talk about the anatomical differences in certain areas. One of the big things is that kids will fall. Remember, their heads are bigger, so when they're running, they're more lopsided or more off-weighted with their head being bigger. They do have gunshot wounds because obviously they see guns and they think they're toys. Blunt injuries are very prevalent. Sports activities are also very prevalent. So psychological differences. Kids may not be able to actually handle pain very well, and they may not be able to tell you exactly where it's hurting, especially if it's like blunt force trauma to the abdomen. They may not know exactly where it's going on. Just be ready for that. Children's bones are softer. We talked about green stick fracture and things of that nature. So they may have broken something, but it may not appear to be deformed. So be ready for that. Collisions and injuries in actual car crashes. So one of the things that always has stuck out in my mind is that mom was rear-ended with her kid in the back. They were probably going 25 miles an hour, probably slowed down a little bit before actual impact. She was hit from behind. She had a kid in the car seat, probably about 2 years old, 18 months old, 2 years old, and it wasn't acting right, but there's nothing visibly wrong with the kid. Well, what had happened was that the kid was properly restrained, everything was good and all, but remember, their heads are bigger. So the head rocked forward and then rocked back and smacked the back of the car seat. Well, that was enough to give the kid a basilar skull fracture. And then he was starting to actually have bleeding into the cranial vault, and so he wasn't acting right. So we flew him, and luckily we flew him, and he wound up having the basilar skull fracture with a head injury. So they can happen. So remember, it could be low impact, and you can still have issues. Head injuries, remember their skull is softer. It's not as well developed yet. You still have fontanelles. So there's a good chance that you can have a really good head injury to a kid, especially if they are roll off or fall. I mean, my daughter rolled off the bed when I was younger, and it scared the bejesus out of me. So usually the telltale signs, still nausea, vomiting, stuff of that nature. Immobilize the kid. If you are going to mobilize, remember to pad the shoulders, because that's going to be something you need to do. Put the seat collar on, pad the shoulders, that way we can keep the airway in line. Chest injuries, just because you don't have broken ribs, remember the chest are more pliable. So if you don't have broken ribs, doesn't mean that something didn't get damaged up underneath there. So the ribs will give a lot more, but they'll also not be able to absorb all of the damage. Abdominal injuries, remember the rib cage is also, remember we showed the picture where it's wider and more out, so the more of the abdomen and the abdominal organs are more exposed and aren't covered as well. So be prepared for that. More blood loss in adult is well tolerated, where less blood loss in a child is not. And remember, they're fine. Nope. So get ready for that. They worry about the injuries to the extremities, like in their legs or their arms, if it gets into the growth plate or the epiphyseal plate. So that's where they want to make sure that does not happen, because if it is injured, it might actually stun their growth or damage their growing. Burns, the skin for kids is not as thick as adults, even though it still has the 3 layers. It's just not as developed, and so it's thinner. So it'll actually, a burn that would not be maybe a 1st degree or 2nd degree for us may actually burn to a 3rd or 4th degree for a kid. So manage them. Be prepared for keeping them warm. Also use sterile stuff on the burns so that we can keep infection out, because the skin is our frontline defense for that. Abuse and neglect, you really need to be highly suspicious. It is up to you to report it. We actually get into a section here in a little bit, or in a minute, about abuse and neglect. So you've got to report it. It's up to you to report that. You need to report it, DFACS, whatever you need to do. However your protocol states for reporting abuse. Infection, like I said, keep them covered, use sterile stuff, use the Parkland burn formula. You don't have to just do a 20 milliliter per kg bolus. Fluid management, you use your Parkland burn formula. Pain management, you can use ice pack. You can probably have to go ahead and use narcotics, stuff like that. Emotional support. There's a jump start for triage. We won't really get into that until we get into triage. Child abuse and neglect. So I'm not really going to talk about all this, but you need to report. Signs of abuse, you need to record your findings. And you need to be as objective as possible. As much as you want to use your PCR to throw the parent under the bus, you've got to be objective to a degree. You just need to report. In your subjective part, which is obviously not being objective, but in your subjective portion, you need to be as objective as possible. You can't say mom and dad, you can't point them out, you can't finger them out. So when you're writing your report, you just need to write what you found, how you found it. There's certain ways that you can write a report in a narrative that'll show that there's abuse and neglect. You can say, upon physical assessment, EMS noted that patient had 5 or 6 bruises, all in various stages of healing, which would indicate that he's being abused. That the various stages of healing means that he got a bruise this day, then a bruise that day, then a bruise that day, and a bruise that day, and this one's healing better or is healed more than the one he's got recently. So there are things you can do to indicate that. You need to tell your receiving facility that when you get there, you probably want to avoid doing it in front of the possible abuser. So there's things to look for. I'm not going to get too into this. But one of the next things that they're going to talk about, burns and fractures, shaken baby syndrome. So if you get called out to a baby, unresponsive, yet there's no real damage, and you know, no one knows what's going on, it could be shaken baby, and that's really bad. That's basically where they just take the baby and just shake it because they're so frustrated, and they wind up scrambling its brain, is the only way I really know how to talk about it. Basically doing a lot of injury inside the brain because it's floating, and it winds up banging around inside, and a lot of cervical damage to the neck. They usually wind up not making it. Neglect is another thing. So you don't actually have to hit the kid or yell at the kid. You can just ignore the kid. Like parents could be home, they could be living with their parents, and they don't get hit, they don't get abused, but like mom and dad have to work a lot, and they don't provide for the child. I mean, you've got to use your best judgment on that, because if they're working hard and they leave kid food and money, and they make sure he's covered with rides and trying to provide for the kids and themselves, then okay. But if it winds up being that mom's just gone out all weekend and she went with her boyfriend for the weekend and left the kid with no food, no money, then that's neglect. Like, they didn't even tell the kid where they were going. So that's more like neglect. Got to report it. Sexual abuse. That's a horrible thing to have to deal with. You'll probably want to kill the alleged perpetrator on scene. Like, everybody will, but you've got to really stay professional and do the best you can to care for the patient that's been sexually abused. Death of a child. There's a lot on death of a child, and this is going to bring us pretty much to the closing part of this. What I'm going to tell you is that death of a child is not easy. It's not easy for you. It's not easy for the parents, obviously, because more than likely they found the child. It's usually going to be chalked up to SIDS, which is sudden infant death syndrome, basically, which is medical terminology for we don't know what happened. The baby just passed away at some point. I know it's tough. There might be lividity. There might be rigor mortis is set up, and you're going to have to tell the parent, like, ma'am, I'm sorry that the child has been down for too long, and you may just wind up saying, all right, there is lividity, there is rigor mortis. We're going to start doing CPR to try to give mom and dad time to see that you're doing something and to transition them. I don't know how to tell you this. This is another one, knock on wood, I've not had to deal with, but I do know how to handle that. One of the things that's going to happen is going to affect you. You might have some PTSD from it. You need to talk to somebody. You need to be able to handle it and still be able to do your job. It's horrible. We talked about sudden infant death syndrome. They have causations for it, but really, honestly, don't really truly know what happened. May want to look to see if there's anything that might have been the cause of it. Again, could be anything. Don't give parents false hope. If you do, like, if they're still appear to be viable, like the patient still appears to be viable, don't be like, yeah, we're gonna do everything we can to try to get him back. Like, don't do that. So you need to kind of sound pessimistic, but give some sort of optimism. I know that sounds kind of counterintuitive, but like, listen, we're doing CPR for them, we're breathing for them. We're giving them drugs. They're not responding right now to the drugs and the treatment and everything we're doing, but we're still going to keep continuing to work and see how this goes. That's kind of the way you need to be with them. Don't speculate the death. Don't try to have a conversation about how they died. That's not for you to determine. There is something called a bruit. You will get called out, and I don't know why this is under death of a child, because it's not really a death of a child, but you will get something called out for something called a BRUE, B-R-U-E, brief, resolved, unexplained event. They used to be called ALTIs, apparent life-threatening event, but now they're called BRUEs. And basically what happens is you'll be called out, and like, I don't know, kid's not breathing, you get called out for child not breathing, limp in mom's arms, whatever. And what happened is the kid's fine, and then all of a sudden they have what is called a BRUE. They just stop breathing, heart stops beating, whatever, and then they just, like, it's like a light switch. Turns off, about 10, 15, 20, 30 seconds, flips back on. So it happens. You'll get called out to those. Those are horrible, because you'll hear, child's not breathing, and all you can think is, why did I show up at work today? But apparently it's my day to deal with it, But then, like, you'll get there, like, I don't know what happened. It felt like the longest time of my life. They're sitting there playing, and I picked them up, and they're playing, or they're crying, and then they just went limp in my arms. They went blue. They turned blue. I don't know what was going on, and all of a sudden, they just kind of came back too. So usually we'll chalk those up to BRUEs, because we don't know what else. We don't know what else to call it. We don't know what happened. So. Yeah, so basically I would transport this child if I were you, especially if this had a BRUE, and just keep an eye on them. More than likely it won't happen again. It's really just one of those weird things that just happens. And that's it, guys. We'll talk to you later.